Hi, my name is Evan Dellon. I'm at University of North Carolina in Chapel Hill in the US, where I am an adult gastroenterologist at the UNC School of Medicine. It's an absolute pleasure today to talk to you about epidemiology of EoE for the ausEE Virtual Education Program and for National Eosinophilic Week 2026. I have a number of disclosures that you can see here. I do work with a number of companies developing new medications, but these are not really pertinent for the current talk. Today, I'd like to discuss how epidemiology has been applied to EoE research and review the epidemiology of EoE, starting with the basics like patient characteristics, incidence, and prevalence, and then moving on to the next steps like risk factors, etiologies, and hypotheses. Let's start with talking about what is epidemiology. So this is the study of patterns and causes of diseases in defined population. These types of studies use observational study design and statistical techniques to make inferences about etiology or risk factors of diseases. So in other words, studies are designed to try to understand what might cause a disease or predispose to a disease. And these are things that you may have heard of called case control studies or cohort studies. When you're doing epidemiology like this, you have to consider things like bias or confounding. So what other factors might explain results besides what you're studying primarily? And these are often the starting place, these studies, for getting ideas or hypotheses to be tested in experimental studies like clinical trials. Why do we need to study epidemiology in EoE? Well, we can't answer a basic question of why an individual patient actually gets the disease. And because of that, we can't move towards screening, prevention, or individualized treatment. So epidemiology gets us on the path to being able to answer this question. And so you can apply epidemiology to EoE in a number of ways. You can do something simple like describe case characteristics. You can use it to help define diseases. You can characterize the number of cases or trends in the number of cases over time. You can describe the natural history of the disease. What happens to people who have the disease is the natural history. And you can identify patterns of people with the disease or cases and risk factors. And the overall goal of doing all of this is to learn how to best treat and prevent disease. So what do we know about the epidemiology of EoE? Well, this is a chronic disease. Essentially, it's lifelong and there is no cure. It can affect anybody at any age, but we do know that symptoms differ by age. Symptoms are in children are quite different than in adults, and part of this difference in symptoms likely represents people moving from a more inflammatory, predominant condition to one where there's fibrostenosis or scarring or stricturing in the esophagus. And I'll talk about this in a little bit more detail at the end, but even though it's a chronic and inflammatory disease, right now there aren't any reports of EoE changing into either hypereosinophilic syndrome or into some type of malignancy. Let's look at the global epidemiology of EoE. This was a systematic review and meta-analysis done a few years ago, and it looked at studies from around the world, and if you total them all up, there's almost 300 million people that they identified and nearly 150,000 people who have EoE. And basically you can see EoE all over the world. In this middle map here, you can see even in Australia, of course, many cases have been reported. And when we think about the number of cases, we think about two types of things. One is the incidence, which is the number of new cases in a given period of time, and the prevalence, which is the total number of cases. And because EoE is chronic, and fortunately people do not die from EoE, as you get new cases, and more new cases, the number of total cases continues to rise. And that's exactly what this study saw over time, over more than 20 years, a small number of total cases, and then this continual rise to their most recent time frame at the end of 2022. And how many people are there? Well, this study calculated there were 5 new cases of EoE per year per 100,000 people, and that there were 40 total cases of EoE per 100,000 people on average. But that's average over 20 years for both of those numbers. So what does it look like for EoE right now? Well, I'll give you this example in the United States where these are the most recent data that we have. But essentially, EoE is continuing to increase in prevalence, or the total number of cases. And you can see here in this graph over more than 15 years, that whether we looked in two different insurance databases, and sure enough, EoE is increasing every year except during COVID when there were less cases performed of endoscopy. And overall in the US, we're now up to about 1 in 700 people have EoE, which means it's about 500,000 people who are known to have EoE in the United States. And you can see there's differences in the number of people with EoE by the state that they live in. The darker colors here have more people and the lighter colors have less people. Who's getting it? Well, as I mentioned before, if you look on this axis, this is age going from less than 5 all the way up to almost 65. Anybody can get EoE. There do seem to be a little spike here in the late teenage years and about 35 to 45. And you can also see that males are more likely to have EoE than females. And this is something that's been shown many times before. But I just want to give you the sense of the increase in all of these age ranges over the last 15 years. So this is what it looked like in 2009. And I'll play this animation here. And you can watch as just the number of cases goes up every single year. And so it's a pretty impressive increase over time. And that may just be the tip of the iceberg. This was an interesting study done by Angela Lamb and colleagues, and they were looking to see what's the burden for people who have EoE who go to the emergency room. And they found about 50,000 people were seen in the emergency room from 2009 to 2019, and that number of people tripled over that time, and they thought there was going to be a doubling of the number of people going to the emergency room with EoE by 2030. And that's all pretty interesting, but if you look here with this box in red, they did another interesting sub-analysis where they asked the question, well, how many people might be in the ER who don't have EoE, but who might actually have it, just haven't been diagnosed yet? So they asked how many people are in the ER who are men under the age of 40, who have trouble swallowing, who might have an esophageal stricture, but who do not have a diagnosis of EoE. And they found that more than 700,000 people fit the bill. And there's not much that would cause that constellation of symptoms and codes and findings except for EoE. So that suggests that there's as many unknown cases as known cases in the US, and that's just males under 40. That's no women, and that's nobody over the age of 40. So there may be a lot of people walking around out there who have EoE, but just haven't been diagnosed. So I think we're going to see an increasing number of people diagnosed with this in the coming years. Now, that's sort of the general population, that 1 in 700 number that's been increasing. But there are people who are even more likely to get EoE, and one group are people who have allergy conditions. Now, we think of EoE as an allergy, and as you all probably know, that the majority of people who have EoE have allergic conditions like asthma or eczema or food allergies or seasonal allergies. It's also called allergic rhinitis. But the flip of that is also true. So somebody who has a food allergy is much more likely to have EoE than someone in just the general population. And so this is a study out of CHOP, and recent data that we've looked at here at UNC confirm this. But for example, if you have an immediate type food allergy, so you anaphylax to peanuts, you have 9 times the odds of having EoE than someone without that type of food allergy. And if you're someone who has multiple allergic conditions, if you have asthma, eczema, and food allergy, there's an increasing chance you're going to have EoE. So if you have 1 allergy condition, you have a relatively lower chance. 2, you're up to here. 3, you're up to almost 1.5%. So less than 1 in 100 chance that you're going to have EoE here. And so it's the more allergic conditions you have, the more likely you are to have EoE. So that's one of the groups we would consider higher risk to get EoE. So all that is prevalence, the total number of cases. What about the number of new cases? Well, that is also rising. This is a graph of all of the studies from around the world, and you can see all the different places here that have reported out new cases, including there's a study here from um, New Zealand. And no matter where you are in the world, the general trend is up, 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 up. More and more new cases of EoE every year. And this is really interesting because it's not just that we're accumulating people at a stable rate, but the rate is really increasing. And that may get you wondering, like, why is that? And is this actually real? Where there's lots of lectures now about EoE, there's approved medications, there's more knowledge about EoE, so maybe people are just finding it more. And this is a study from Denmark that I was able to participate in. And the reason that we did this study in Denmark is we were able to identify every patient in the country that had EoE, and we were also able to identify the total number of procedures, endoscopies with biopsies in the country. And in fact, over this 15-year period, we saw that EoE was increasing very rapidly, but we also saw the biopsy rate and endoscopies was increasing as well. But if you look at the scale, the biopsies increased about twofold, whereas EoE increased about 20 to 25-fold. So the EoE was increasing far more than people were looking at it for it. It's not like we did 25 times more endoscopies with biopsies. And this has then been replicated in other places. This is just an example of one study from Switzerland where you see the same thing, a very rapid increase in EoE and just a mild increase in the total number of endoscopies and biopsies. This has been seen now in Korea and also in Sweden. So it does seem like EoE is increasing even more than people are looking for it. And when you see increases that are this quick, it's not genetics. Our genetics don't change so quickly over just 15, 20, or 30 years. And so the idea is there's probably something changing in the environment. And this is a study that looked at twins. And if EoE was 100% genetic, then 100% of identical twins would have EoE. But that's not the case. In this study, only about 40% of identical twins, twin pairs, had EoE. So in other words, that's one twin with EoE, one twin without. Now that's still a bigger risk, 40%, than the 1 in 700 in the general population. But you can see even lower for non-identical twins. And then between siblings, it was just about 2%. And, 2 out of 100 or 1 out of 50 is still more than 1 out of 700. But the genetic part of this is relatively low, about 15% compared to 85% contribution from the environment. So why is EoE increasing? We know it's not just this increasing recognition with the number of papers and looking at it more, but what environmental factors might be changing? Well, there's been a lot of work done on this and a number of candidate possibilities. One option is actually not something that's been increasing in the environment, but something that's decreasing, and that's H. pylori. H. pylori is the bacteria that infects the stomach, and it can cause gastric ulcers and small bowel ulcers and gastric cancer. And this used to be very common, but since its discovery as a cause of ulcers in the early 1980s, it has been treated and eradicated when it's found. And so you've got a situation where H. pylori is going down quickly. At the same time, EoE is going up. And there is some possible rationale for why the lack of H. pylori might be causing EoE, but this also might be related to what's called the hygiene hypothesis, where we're all growing up in an environment that's too clean, and people aren't getting exposed to the kind of things that they should get exposed to have their immune system be tolerant to environmental factors. Another possibility is population density. And we typically think of allergic conditions being maybe more common in rural areas than in cities, but EoE, it looks like it's the reverse. So in this study, in this map of the US, where the colors are red, that's a place where there's a higher relative chance of having EoE. So even though, for example, say here in Los Angeles, there's a raw number, very high number of EoE cases. As a relative number, it tends to be lower, whereas in part of the state here, which is say North Dakota, there's not that many people, but on a relative basis, it's more likely to have EoE. So is something going on in these rural areas here, up here, where There may be environmental factors for EoE, farming practices, pesticides, vegetation. There's been other associations between EoE and climate zone, like dry and arid climate zones, certain housing materials, and then more recently, just general poor environmental quality, particularly related to water quality, proximity to commercial farming, and maybe even particulate matter. So all of these are really interesting, but what has to be done is the next step, which is trying to figure out why these exposures make a difference in individual people. Right now, these are just what we would call ecologic associations, and you have to be careful about this because it's associations that may not imply cause and effect. And I really, this is one of my favorite figures because it shows you a really strong relationship between chocolate consumption and the likelihood of having a Nobel Prize winner in your population. You can see there's a very strong relationship between having more coffee and more Nobel Prizes. And Switzerland is the country that has the most chocolate and the most Nobel Prize winners. Australia is down here, we're close to the United States, kind of in the middle of the pack. But we know this isn't true. So this is what would be an ecologic association. Where else are we looking for associations and potential clues into risk factors for EoE from the epidemiology standpoint? One place would be looking at early life exposures. In other words, things that happen to babies early in their life, typically from under the age of 1, where it's a sensitive time for development of the immune system, and factors that are in the environment may impact that immune system development and predispose the immune system from becoming tolerant to things in the environment they should be tolerant to. So to explore this and to build on previous data that were suggestive of a number of early life factors, including early life antibiotics, neonatal ICU stays, cesarean section delivery, and possibly breastfeeding, we looked again in a study in Denmark where we could look at the whole population and find out what happened to children and then see if they developed EoE. And the first thing we looked at was antibiotic exposure. And so you can see here, if children got antibiotics within the first year of life, if compared to getting no antibiotics, the more prescriptions they got, the more likely it was that they would ultimately be diagnosed with EoE in childhood. Same thing for the number of days. And there seemed to be a period maybe between 0 to 6 months of age where the exposure was more likely to lead to EoE. And it wasn't just the babies. If their mothers were exposed to antibiotics during pregnancy, they had a higher chance of having a child with EoE compared to mothers who did not get antibiotics. And that's the same thing with increasing days of dosing, and perhaps there's more chance of having the child ultimately have EoE if the antibiotics are later in pregnancy. And then we saw a similar trend with antisuppressants, and these were antacids of any kind compared to people who had no antacids. Babies who had antacids within the first year of life had a very high chance, well, had an increased chance, let's say, of getting diagnosed with EoE later on. And that's the same thing with the increased number of dosing and, with increasing age up to 1 year as well. But what's interesting about these data, in addition to sort of the relationship, is that you might say, well, millions and millions of children get antibiotics and millions of mothers get antibiotics and maybe even more get antacid. And it's not millions and millions of people who are getting EoE, it's a subset of those. So it's not just an issue with the early life exposure. Instead, it's likely that exposure may only make a difference if there is perhaps a genetic susceptibility or some other predisposition to then get EoE. And this was a study done with Elizabeth Jensen and colleagues where we looked at that possibility using breastfeeding as a risk factor. And we examined that environmental risk factor in the context of a gene that's involved with the barrier function of the esophagus. And what we saw was very interesting. We saw that if you did not have an abnormal gene, what's called the risk allele, it didn't matter if you breastfed or not your child, that child was not likely to get EoE. However, if that child had the risky gene allele, which would be a predisposition, if that child had that predisposition and was breastfed, that child actually had less likelihood of getting EoE. But if that child had that predisposition and was not breastfed, they had an increased chance of having EoE. And that's the gene-environment interaction. The risk factor only comes up if you have both that gene predisposition or risk allele and the risk factor, in this case, not breastfeeding. So this is proof of principle that this can happen. And now it's clearly not going to be this simple. It's likely going to be many genes, 20, 30 or more, interacting with multiple environmental interactions. And so this is something that's being under study and in a much more complicated way going forward. So to summarize how we think of all of these risk factors that we've learned about from the epidemiology of EoE is that we have a number of environmental factors. For example, the antibiotics that I talked about or cesarean delivery. You have a bunch of other environmental you have these are the early life factors, and you have a bunch of other environmental factors, maybe the water quality or the population. And then these will interact not only with genetic predispositions and that gene-environmental interaction, but it also interacts with the lining of the esophagus and how good that lining is at keeping out these environmental factors. And this constellation of things is what may lead to EoE in a given person. Now, this is still just the model, and we couldn't say for you, or for my patient in front of me, which of these may be at play. We still have a lot of work to do until we can get to that point. Now, a couple last points about the epidemiology. By studying the epidemiology, we are able to understand, as I mentioned, that EoE is not only chronic, but that if it's not treated, we understand that people will move from being mostly inflamed in their esophagus to getting a lot of scar tissue, and that leads to those trouble swallowing and food impaction type of symptoms. And this illustration here kind of models that, going from inflammation down to a more narrow esophagus over time. And these are some studies that show you the longer that patients have symptoms before they get diagnosed, going from almost no time to more than 20 years, they go from having a relatively low amount of strictures, maybe 30–40% of people who only have symptoms for 2 years will have strictures, compared to 80% plus of people who aren't diagnosed until after 20 years of symptoms. These are data from Switzerland, exactly the same type of data shown in the Netherlands. Just the graphs are basically displayed in a different orientation. And then the last point I wanted to talk about, I know a lot of people are probably concerned, I have inflammation from EoE in my esophagus. Could this lead to cancer? I know about reflux, and Barrett's esophagus is a risk factor for cancer. And thankfully, there have been a couple of studies now that have looked at this. And the bottom line is it doesn't seem like EoE is a risk factor for cancer from what we know right now. And this was a study here using US data and insurance databases and a study in Sweden. And this is a meta-analysis of all of the literature. And basically, there is not evidence that EoE is a cause of cancer. And so that's, I think, really reassuring, but this is clearly something that people are researching. But for right now, that's at least one thing people who have EoE don't need to worry about right now. So to summarize, I would just say that we've talked about epidemiology in general, and I hope I've shown you that the epidemiology of EoE is becoming better understood. Right now, the disease is really well characterized from the clinical standpoint, and we know the patterns of disease. We know that EoE is rising rapidly, both in incidence, the new cases, and in prevalence, the total number of cases. In many places, EoE is no longer a rare disease. That's certainly the case in US and Australia and Western Europe and parts of South America. And now we're really getting into the nitty-gritty. Why is this? Is this from a general increase in allergic diseases? What are the environmental factors? What are the early life exposures? What are the gene and environment interactions? And then clearly other risk factors are going to be identified. So thank you very much for listening to me, and thank you for participating in the National Eosinophilic Awareness Week.